Focus on Health, your weekly dose of health and wealth information on KUTV.
Welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Jebel Fender, and on this episode, we discuss gestational diabetes alongside Dr. Boniface Musila of the Kenyatta University Wellness Center. Before we dive into this very interesting conversation, take a look at the health updates. Very informative health updates right there. And like we said, we are discussing gestational diabetes alongside Dr. Boniface Musila. So kindly, Doctor, introduce yourself to our audience.
My name is Boniface Musila. I'm a medical doctor, an obstetrician gynecologist, and I'm also a lecturer at Kenyatta University School of Medicine at the Department of Obstetric and Gynecology.
Okay, so what is gestational diabetes?
So, gestational diabetes is defined as an intolerance to carbohydrates that of varying degrees that is diagnosed or first recognized during pregnancy, and after the pregnancy, the blood sugar control or the carbohydrate intolerance goes away. So it is a condition that is specific to pregnancy.
Okay, and is it different from type 2 diabetes?
Well, it is slightly different from type 2 diabetes because it is an entity that is specific to pregnancy. However, women who get gestational diabetes later in life have a higher risk of getting type 2 diabetes. So they should beware and watch what they eat and implement measures in their lifestyle that would prevent them from getting type 2 diabetes. But this condition is specific to pregnancy, that is gestational diabetes.
Okay, and what are the risk factors associated with gestational diabetes?
So who is more likely to get gestational diabetes? One is women who have a strong family history of type 2 diabetes. Number two, women who have previously in their pregnancies delivered babies who are classified to be big. So these are babies who weigh anything more than 4 kilograms. So if somebody has ever had a delivery and the birth weight of the baby was more than 4 kilograms, they are at a higher risk of getting gestational diabetes. The third risk factor is women who are obese. Yeah, they are more likely to get gestational diabetes. Four, women who have multiple gestation, so women who have twins or triplets, they are more likely to have gestational diabetes in their pregnancy. Also, when we are doing assessment during pregnancy, in case we notice that the women, when we scan them and find that their babies are slightly larger than what would be expected in their gestation, we call them large for gestational age, they are more likely of having gestational diabetes. Women also who have had recurrent pregnancy losses, we are talking about first trimester pregnancy losses, and multiple of them, recurrent pregnancy losses, they are at a higher risk of getting gestational diabetes.
Okay, and so why this sudden intolerance to carbohydrates? What's the cause for that?
Okay, the cause is associated with some hormones that predominate during the period of time that during pregnancy, where women are more prone to getting gestational diabetes, and this is between 24 and 28 weeks. Generally, there is a change in metabolism during that time. Remember, it is the second trimester, And metabolism changes like to an extent that the sugars are availed to the baby. Remember, sugars, that is glucose, crosses from the mother side to the baby side, where it is utilized for growth and development. And the changes in metabolism happen so that the sugars are availed, and there are specific hormones that are associated with that change. And these hormones originate from the placenta as part of the pregnancy changes. So specifically, we have a hormone called human placental lactogen, HPL, that may reduce the body's sensitivity to insulin and avail more sugars. Also, we have cortisol. In addition to the usual hormones that we know, estrogen and progesterone, which are steroid hormones, and they may cause a bit of sugar intolerance. So all these problems culminate into either resistance to the body, to the target organs of insulin in the body, such that the insulin is there, but it may not be effective in lowering the blood glucose levels after somebody eats, or it may affect the production of insulin, such that the levels of insulin that are produced are less than the requirement because of the pregnancy. And that may tip a woman who has other risk factors for gestational diabetes into now having full-blown gestational diabetes.
Okay, and how does gestational diabetes affect the mother and the fetus?
Now, on the mother's side, when the the gestational diabetes culminates in high blood sugars in the woman. Now, these high blood sugars, one, increase the blood glucose levels in all the body secretions. You're talking about the urine, you're talking about the vaginal secretions. So this woman is at a higher risk of infections. So we are talking about infections like urinary tract infections, which may adversely also affect the pregnancy. We are also looking at infections like vulvovaginal candidiasis, which presents with vulval itchiness and vaginal itchiness under discharge, and they may be more common, on the woman, or on the side of during pregnancy. Apart from that, the women may experience accelerated vascular changes. Remember, when the blood sugars are high, they may affect the blood vessels. So we are talking about the blood vessels in the eyes, that may accelerate the eye damage. All right. We are talking also about the kidneys that may be adversely affected. In worst case scenarios, if the blood sugars are too high, there are some acute complications like diabetic ketoacidosis, where the woman may get into coma because of very high blood sugar levels. It's usually a medical emergency. Apart from that, the pregnancy may be affected by what we call polyhydramnios, meaning that the amniotic fluid level is too much. During it is too much production of the amniotic fluid, and that may make the baby bump, the pregnancy, look big, and that may weigh down the woman. Now, when it comes to the third trimester, when that condition is not cognized, women have ended up with losing their babies for some unexplained reasons. So a woman just realizes that the baby has stopped moving, and when we do an ultrasound scan, then we find that the baby has died inside the womb. So one of the causes is gestational diabetes mellitus. Also, during the process of giving birth, because these babies tend to grow excessively, there may be damage to the reproductive tract. You can imagine someone delivering a baby who is more than 4 kgs. So during the process of giving birth, there may be tears in the reproductive tract. We are talking about cervical tears, vaginal tears, and also injuries to the perineum and the birth canal, which may adversely affect the mother. Also, the pelvic bones during the process of giving birth may be injured together with the nerves. So when the pelvic bones are injured, we call that diastasis of the symphysis pubis, and it may make walking very difficult. Also, the nerves may be injured, and women who have given birth vaginally with very big babies have ended up with the foot drop. Now, because of the problems of the size of the baby during birth, women may end up with the prolonged labor, right? And the prolonged labor may lead to cesarean section. And cesarean section has a higher risk of complication. We're talking about things like bleeding, things like wound infections, and the risk of further operations later in life. So on the fetal side, the babies may grow excessively because of the high amounts of blood glucose that is passing through the placenta to the baby's side. And this excessive growth may affect the baby in terms of the size and also production of excessive amniotic fluid. And there are also other complications, especially when it comes to the formation of the different body organs. There are some congenital anomalies that are associated with the gestational diabetes mellitus. Also, as I said earlier, this is now combined maternal-fetal. The babies may die during the pregnancy, especially later during pregnancy, so fetal demise. And also during the process of giving birth, there may be injuries to the baby. Babies have had fractures of the bone of the arm, that is humeral fractures. Babies have also had injuries to the nerves. Yeah, there's a specific condition called shoulder dystocia that occurs during the process of delivering big babies, and that may cause injuries to the nerves of the upper limb of the arm and the forearm. Now, because these babies also may grow excessively, especially when the blood sugar control is not optimal, immediately the mother is disconnected from the baby. Once the umbilical cord is cut, we have a baby with very high levels of insulin because the baby's body reacts to the high blood sugar levels during the pregnancy by producing too much insulin. So we have too much insulin circulating in the body. While at that time, once the baby is born and the umbilical cord is cut and the baby is disconnected from the mother, they may not have enough carbohydrate reserves, so they may not have enough sugars. So this high level of insulin makes the baby's blood sugars to drop drastically, and that has caused neonatal deaths. Also, because of the size, these babies are more prone to having jaundice during the neonatal period. Once they are born, they may also have hypothermia. This is they are more prone to having low temperatures, so they should be nursed in a warm area. Yeah, so those are the commoner complications on the maternal and the fetal side. On the fetal side, apart from what I've mentioned, they may get low calcium levels, yeah, and so on and so forth.
We're taking a short commercial break, but do stay with us and do not touch that dial. We'll be right back. But before then, take a look at the Did You Know segment. Welcome back to Focus on Health. We are continuing the conversation on gestational diabetes alongside Dr. Boniface Musila. Take a look. Okay, so how do you investigate a woman who you suspect has gestational diabetes?
Okay, the first thing we do when we are booking, because most of these women may not be aware of their status, and they may not even know that for those ones with pre-existing diabetes, they may not be aware that they have it because it may be mild, especially type 2. At the booking clinic, which we recommend in trimester 1, we usually do a random blood sugar or a casual blood sugar. This is just a blood sugar without any fasting and so on and so forth. So if it is above a certain threshold, if it is above 11.1 millimoles per liter, then we know that there's a problem. Yeah, if it is within the normal range, then that's okay. We continue monitoring the pregnancy, and at between 24 to 28, we order a specific test called oral glucose tolerance test. So what happens is that the woman comes, we schedule a visit at between 24 and 28 weeks. And during the scheduling, we give instructions to the woman that she shouldn't eat anything in the morning, even drinking water. So we do the fasting blood sugar, fasting plasma sugar after an 8-hour fast. So after dinner, you're not supposed to eat anything, even drinking water. So we usually check, once they show up, usually do the fasting plasma sugar. And if it is more than 5.1, then it means there is a problem, okay? So if it is normal, then we give them a blood sugar level. So this test is called oral glucose tolerance test. So we begin with the fasting plasma sugar after an 8-hour fast. After that, we give a glucose load, which is usually 75 grams according to the WHO, and we keep on testing the blood sugar. So we have an 1-hour measurement and a 2-hour measurement. So the 1-hour measurement, the level is supposed to be up to 10. So anything less than 10 is okay. The 2-hour measurement is up to 8.5. Anything less than 8.5 is okay. So when the thresholds are more than that, then we will make a diagnosis of gestational diabetes and then manage appropriately according to severity.
Okay, and is it possible that the condition gets worse if, per se, the woman has diabetes already prior to pregnancy?
Yes, there is a possibility that if the adjustments are not made for a woman with pre-gestational diabetes or pre-existing diabetes, it may worsen during pregnancy. And that's why for those ones with either type 1 or type 2 diabetes that existed before pregnancy, we must optimize them for the pregnancy. So they should have scheduled visits between the endocrinologist and the obstetrician so that we can change them to medications that are safe during pregnancy, and we can continue to monitor the situations because the demand for for insulin increases because of the pregnancy, and it may worsen the situation. So if we don't readjust that to higher doses, then it may worsen the cardiovascular effects of diabetes. So we are talking about the effects on the eyes, effects on the kidneys, and so on and so forth.
Okay, so how do you manage gestational diabetes?
So gestational diabetes is a multidisciplinary, is a condition that is managed by a multidisciplinary team. It is not only for the obstetrician. So we usually incorporate a nutritionist because a nutritional counseling is very, very important. And we reorganize the meal plans so that at least 30% of the meals come from carbohydrates. So the idea here is to tone down on carbohydrates and increase more of energy sources from proteins. And we encourage also more vegetables, so proteins and vegetables, and tone down on the carbohydrates. But the nutritionists are the ones who know this better, and they will offer advice. Also, the endocrinologist or the physician has a great role in managing these conditions because they are the ones who will recommend the medications for lowering the blood sugar. Of course, there are some medications that are safe during pregnancy, especially some oral medications like metformin when the condition is not severe. Sometimes when the condition is severe, then the physician will have to, the endocrinologist or the physician will have to introduce insulin. Now, for us in obstetrics, for us obstetricians, our work is to monitor the growth of the baby. For those women with pre-gestational diabetes, we do a comprehensive anomaly scan at between 18 and 20 weeks to look for congenital anomalies that may be associated with pregestational diabetes. So once we scan and we find that there are no anomalies, of course, we continue monitoring the growth of the baby, and we correlate the growth of the fetus to the blood sugar control. So we keep on doing scanning, usually every month, to check whether the growth pattern of the baby is normal, is appropriate for the gestational age. Because sometimes you may have large for gestational age babies, which it may be a pointer on the blood sugar control. If the blood sugar control is not good, we may end up with large for gestational age babies. So also monitoring during pregnancy by the obstetrician helps prevent complications, especially for those women who have had fetal demise in utero in previous pregnancies. We keep on assessing the biophysical profile of the baby to make sure that the baby does not get sick. And we also time the delivery because based on the maternal and the fetal condition and the blood sugar control. So that is important.
Okay, so you mentioned in a previous episode that the management of preeclampsia could include just delivery. Does that also work the same way in gestational diabetes?
Yeah, gestational diabetes is a bit different slightly in that we time delivery so that we can, one, prevent excessive growth of the baby, okay? But we have to tailor that to the maturity, yeah? So we have to test and ensure that the baby is mature before delivery. Most of these babies, especially when the blood sugar control is not okay, tend to be larger. So we also decide on which method of delivery is best, okay? Of course, for preeclampsia, eclampsia, most of those babies may have growth problems because of hypoxia, like issues with oxygenation, because that condition may have affected the, supply of oxygen to the baby's side. For these ones, for gestational diabetes or pre-gestational diabetes, they may be larger for gestational age. But what is common between the two conditions, especially for gestational diabetes, once delivery happens and the placenta is out, so we get rid of the hormones that were causing insulin resistance, most of the times the blood sugar control goes back to normal. Okay. Yeah.
So, and as we conclude, are there ways to prevent gestational diabetes?
Okay, the ways to prevent gestational diabetes is one, ensuring that for those women who have risk factors, they can lose a bit of weight, especially for those ones who are obese. Also, diet modification during pregnancies, okay? We usually advocate for a balanced diet because, of course, as a woman, you will need that energy, all right? So there's no need for, excessively fearing some foods. We know that traditionally people have thought that and have been prevented from eating some foods because they will make the babies grow excessively big. But that is a myth. What most of the times makes the babies grow excessively big would be issues to do with undiagnosed gestational diabetes. But we know that there are other contributors to a big baby. Yeah, if you have big parents, maybe big mother, big father, you're more likely to end up with a big baby, but there may be some contribution from carbohydrate metabolism. So eggs are safe, right? They do not make the babies to be excessively big. We advise just someone to eat all the components of the diet, that is carbohydrates, proteins, fruit and vegetables in moderation. I know there are also a lot of cravings that may show up during pregnancy. And this may be a pointer to a problem. So for anyone with this, then they may need to be reviewed. Remember, by and large, because this is a remark in conclusion, most of women with gestational diabetes may not even be aware because they may not have subtle symptoms. When the blood sugars are very high, people may notice that they are peeing more frequently and so on and so forth. But for some of them, the symptoms will be quite subtle, like some headache here and there, some fatigue that is a bit unusual. Some of these symptoms are also common, pregnancy symptoms. So there may be a thin dividing line between what is normal and what is abnormal. So, but when some of these subtle symptoms become a bit persistent, then it would make sense to check into a clinic or a hospital and get assessed.
Okay, would you also consider lifestyle modification prior to pregnancy?
Exactly, yeah. So lifestyle modification is very important. We have an outbreak of non-communicable diseases, and diabetes is one of them. So even as part of lifestyle modification, we advocate for exercise, getting adequate exercise, and also modifying our diets to exclude excessive sugars and excessive carbohydrates.
Okay. Okay, so Dr. kindly give us your parting shots in relation to gestational diabetes.
My parting shot from the data that I have is that this condition called gestational diabetes, the incidence is increasing. Like, we are seeing more and more cases, and I know in our guidelines we have as part of the antenatal care profile, we have random blood sugar testing for every woman. So I'd advocate all women who are expectant to go for their routine clinics because this is a time that we'll identify problems. And I'll advocate also for the glucose tolerance testing almost routinely for all pregnant women at between 24 and 28 weeks.
Okay, and Dr. where can we find you?
All right. Apart from lecturing at Kenyatta University School of Medicine, I also do private, clinical work at AAR Healthcare, that is in Embakasi and Syokimau Gateway Mall. I have my clinic, which is located in Utawala area along the Eastern Bypass. Yeah. Alternatively, also, I do admit in most hospitals in Nairobi, including the Nairobi Hospital, AAR Hospital, Coptic Hospital, Private Wing, Kenyatta Hospital, Komarok Modern, Metropolitan, MP Shah, Avenue, Mata, and many more.
Okay, so thank you so much, Dr. for that conversation.
Welcome. With pleasure.
Very informative conversation we've just had, and just as Dr. has emphasized, lifestyle modifications is important in preventing gestational diabetes. I have been your host, Jebo Fenda, and until next time, stay safe, stay healthy. I'll leave with a Healthy You segment.